So it's a highly androgenic and progesterone-ridden pregnancy, low estrone, estrone sulfate, and insulin-like growth factor 1. This procured my interest in whether this androgenic pregnancy could be associated with reduced risk of breast cancer in women. So my colleagues and I in Norway decided that we would first review all the literature on whether this could be so. And what we saw in one of our articles is that among women who had preeclampsia compared to women who did not, there was anything ranging from a 70% lower risk to a 40% higher risk of breast cancer. But the numbers in these studies are very small. And the daughter's risk was something from a 10 to 60% lower risk of breast cancer among a daughter of preeclamptic compared to normotensives. So what we did, because we were in Norway, Scandinavia has this extraordinary, beautiful data where you take someone's ID at birth and you link it to the prenatal data of the mother in pregnancy, and then wrap it around and link it to the cancer registry data. We linked and identified from all of the women who delivered from 1960 on in Norway, the women who were preeclamptic, okay? And then we identified a set of normotensives, women who didn't have preeclampsia. We matched on parity. We only wanted women who had their first birth. Why? Because preeclampsia is a high-risk pregnancy. Many women don't have subsequent pregnancies. And because the first pregnancy has a much higher hormonal milieu than subsequent pregnancies. So we wanted a primipara with a primipara matched. And then we wanted to match on maternal age of birth, because maternal age at first birth is a risk factor for breast cancer and a risk factor for preeclampsia. With this matched data set, we identified about a 14% lower risk of breast cancer in the women who had preeclampsia compared to the women who did not. Because we also knew that pregnancy, hormonal milieu of pregnancies differ by the sex of the offspring, with the pregnancy of a male being far more androgenic than a female. We stratified by sex of the offspring, and here's what we found. What we found essentially was a very strong signal for reduced breast cancer risk by about 21% in the women who had preeclampsia and delivered a son, compared to what we would call the normotensives henceforth, who delivered a son. But the signal for women who had preeclampsia compared to normotensives and had daughters was really non-significant. It was about 6% reduced risk. So this is the first study where we actually had adequacy of numbers and adequacy of linked data to look at the signal for preeclampsia and breast cancer risk. Okay, but we wanted to know why. What is going on here? Why is this so? So, here we are. We're in Norway. And in Norway, you see this dot here? It's rather large for the size of the province. Thanks to my student who did this slide for me. This is Stavanger. Stavanger is a province in Norway on the fjords. It's got beautiful white sand. And in Stavanger in the 1990s, the head of the hospital was an OBGYN named Steintor Nielsen. He was very interested and concerned with sudden death syndrome at that time. And he collected data on all births in 1993, 94, and 95, and cord blood as well, and all the maternal data that you wanted. He also diagnosed all the preeclamptics. So we approached Steintor to be involved in our research study. And so we had a population base of 3 birth cohorts born 93, 94, 95, a total of about 12,000 or more births that occurred in those 3 years. We identified 307 cases of preeclampsia that I had subsequently validated by dipstick and diastolic blood pressure, and 2 sets of controls. This one set of controls was a baby of the same sex, born on the same date as the baby of the preeclamptic pregnancy. So a birth date match, birth date and sex. The other one was a control that matched our maternal age and had delivered a same-sex offspring, but not on the same birthday. So, in the annals of epidemiology, what did we have? A nested case control study within birth cohorts, right? Okay, so we then had these 3 years of births. We linked all the data on the prenatal record of all of these women to data on all of their well baby checkups and other clinic visits across the life course until they were about 10 years of age. Our first follow-up was at 10.8 years because in Norway, and this, I'm talking about the girls only in this research that I'm talking about today, 10.8 years is the median age for breast development, Tanner stage B1, B2. And the second follow-up was at 12.8 years because that's the median age for Tanner. Okay? And we used a follow-up by enrollment of letters. And, so if I can go past here. Okay, good. So then our aims in the pubertal study was to compare the offspring of preeclampsia, the daughters now, to the offspring of normotensives by Tanner's breast and pubertal stage and pubic hair stage, anthropometrics, waist and hip circumference, height and weight, and blood hormone levels. We hypothesized that the offspring of preeclampsia will delay puberty, will be shorter and heavier, have lower IGF-1 and estrogens and higher androgens and leptin as we follow them over the life course. Stick with me, and usually the null hypotheses, but I have a lot of alternate hypotheses. Okay? Here we go. So here are our growth trajectory data. This is Christine Byberg's dissertation, and she did a beautiful job. What she did was, Norway has growth reference data, and so we actually created z-scores for length on the top axis here, length by age until 2 years for recombinant length, and then from 2 years on until 12 years of age for height. And we stratified into the girls of the severe preeclamptics, this blue line, the girls of the mild to moderate preeclamptics, this looks like yellowish line today to me, and then the green is the daughters of the normotensives, okay? And what we're seeing at birth is clearly the daughters of the preeclamptics are much shorter than their peers, and this is retained throughout the life course and all the way into the height data until they reach menarche. So indeed, we see a dramatic difference in the severe preeclamptics compared to the mild to moderate and the normotensives for height until right at menarche. Well, for weight, what we found was, again, the severe preeclamptics were significantly thinner or lower with birth weight than their peers. The mild to moderates and the normotensives are very, very close. It's no significant difference. But the difference for weight shows in this part of our slide right here. The adipose rebound occurs about 6 years of age. And at the adipose rebound, what we're really seeing is our severe preeclamptics cross over the normotensives and come to the same weight as their peers who are the offspring of the mild to moderate preeclamptics. And so the weight trajectory does indeed show that the girls are heavier at a certain age, 6 years of age, compared to their peers. But in height, they are spot on. Okay, so whoops, good. So now let's turn to breast development. What we did for breast development in Norway, which is what you cannot do in the United States, is Anders Juel, a very famous endocrinologist, came over to Norway and trained our nurse researchers for breast palpation. They actually palpated the breast to distinguish the gland from the fat tissue. And we're trained and trained and trained in this until I think they were blue. And here's what we saw. Okay, so we're talking about breast development first. We're talking about Tanner stage 1, which is prepubertal, and 2 is onset of breast development, 3, 4, 5, to mature breast. And what we saw was, and you can see it in these pie charts, it was clear as day, there's no difference in breast development at 10.8 years between the daughters of preeclampsia and the normotensives. Pubic hair development, same picture. So what's going on, folks? We went to now 12.8 years of age. Oh, no, let me talk to you about this first. Okay, so then I have this student, Jeremy Shore, who's now an assistant professor at Baylor. And Jeremy and I developed a life course model of the risk factors across life course associated with the odds of actually breast development by 10.8 years. And what we found, this is our early life model, this is our childhood model, and this is our model across the life course of childhood on the top and up early life, and you can see on the top and on the bottom chart. And what you're seeing in this life course approach here is that, in point of fact, girls of pre-eclamptic in utero exposures have a 71% reduced risk, after you adjust for other factors, for breast development by 10.8 years. Almost all the women exclusively breastfed in Norway, except for 4%, so we're not counting out many people here. And then, if your mother is heavier or you are heavier, these are large signals that are increasing in the odds of breast development by 10.8 years. Okay, what about breast development at 12.8 years? Same team of nurses, retrained and re-standardized. And what happened at 12.8 years is that 8.3% of our daughters of the pre-eclamptic pregnancies did not even have the beginning of breast development. 13.9% had breast development. And clearly, we can see that they were absolutely pre-pubertal, more pre-pubertal than the daughters of the normal intensives. And in fact, as we follow them over the years, this pie chart remains largely for breast development on our pre-eclamptics. So something is happening here. We have blood hormone data that I won't present today that does corroborate some of this for estrogens and for IGF-1. Pubic hair development is just the opposite. So, we've got these two paths for pubertal development. We've got breast development and pubic hair development in girls, right? And here, the daughters of preeclampsia have a much higher percentage who are Tanner stage 4 for more advanced pubic hair development at 12.8 years compared to the daughters of the normal intensives. So there's a difference in the pathways to pubertal development in our daughters of preeclampsia pregnancy. Okay, I'm going to turn now to the mothers, because I told you that this is a pregnancy that not only has an imprint on the daughters, but it has, and the sons. I'm not presenting the sons' data today, but I also said there's an effect on the mothers. And here's what we did. We stratified and looked at cardiovascular disease and metabolic syndrome in the women who were the normotensives, the mild preeclamptics, the moderate preeclamptics, and the severe preeclamptics. What you're going to see is that the weight of the mild and moderate preeclamptics, this is 11 years postpartum, and the daughters are 10.8 years of age, is significantly heavier in the mild to moderates compared to the normotensives and the severes. Likewise, the percentage with diabetes are significantly greater in the mild to moderates compared to the severe and the normotensives. And finally, the percentage on antihypertensive medication are clearly more in the mild to moderates compared to the severes, none, and the normotensives. When we turn to some blood hormone levels, we also see glucose, insulin, HOMA-IR, in the mild to moderates are significantly greater than the normotensives or the severes. And it's only the signal for diastolic blood pressure by 11 years postpartum where we see the signal across the severes as well as the mild and moderates that are significantly greater than the normotensives. So we're seeing, in effect, a difference in the preeclampsia depending on the stage of diagnosis, the level of hypertension and the pregnancy, and the impact both on the mother as well as the fact that these babies of the mild to moderates had more large dates. So let me just summarize the data on the life course of preeclampsia as I'm presenting this picture. For the female offspring, they delay breast development but accelerate pubic hair development by 12.8 years. They're heavier than their peers by about 11, 12 years of age. Mothers and child's weight are associated with breast development at 10 years. The mothers at 11 years postpartum are all hypertensive, and the mild to moderates, these are the preeclamptics, right? Are all hypertensive, but the mild to moderates are overweight and insulin resistant. So very different pictures of what's happening with these women over time. Okay, so now I'm going to turn the dial in another series of studies that we've done on the life course. How am I doing on time? And we're going to talk about the obesogenic environment in utero in early life. And this slide just sort of familiarizes sets of risk factors related to obesity, maternal age, hypertension, gestational diabetes, preeclampsia. Obesity is a risk factor. Race, ethnicity varies by percentage of pre-pregnant obesity and parity. Diet, pre-pregnancy BMI, weight gain, our physical activity are truly some of the factors that some of which we could try to translate and change. So I've been involved with the Nurses' Health Study now for 30 some odd years. And in the 1990s, Karen Michaels and I and Walter Willett sat down and said, we've got to do something understanding the nurse's early life. So I posed the Mother's Cohort Study to the Nurses' Health Study. And what we have here is the Nurses' Health Study 2. This is a prospective cohort in 1989 of over 100,000 female nurses. You all know about this biannual follow-up of health behaviors and medical history, right? And we linked it to their mothers. In 2000, we had about 51,000 mothers who were still alive of these nurses. About 36,000 of them actually responded to our questionnaire that we sent